Welcome, dear ladies and gentlemen, and participants of the 5th Pancreas Cancer Academy. I'm Krzysztof Zielinski, and I'm president of the Central European Cooperative Oncology Group, which has the pleasure, the honor, and this distinction to organize the Pancreas Cancer Academy since its very beginnings now many years ago. Now, the Pancreas Cancer Academy would have never succeeded as well as it did without three factors. The first and most important factor is having a wonderful faculty, and this wonderful faculty is truly chaired, organized by Professor Gerald Prager, who for many years was a co-worker of mine and whom I have the pleasure to call a friend and a great human being. But not only this, he's also a wonderful physician, a wonderful oncologist, and has become one of the world's leading experts in the treatment of gastrointestinal malignancies. Therefore, I'm sure the faculty which he has gathered followed his call to participate in the Pancreas Cancer Academy, which we launched. Now, after 5 meetings on the internet, and we have today the 6th webinar, we are very, very happy to announce that we had very, very many participants, 390 in total, coming from 57 countries across Europe, Asia, the United States, Middle East, and South America. Now, this constitutes truly the second pillar of the endeavor of the Pancreas Cancer Academy. That is, it consists of a very interprofessional and multi-professional faculty. This not only involves different specialities from medicine, like medical oncology, radiotherapy, surgery, and others, but also nurses and also patient advocates. This makes the Pancreas Cancer Academy very special and truly unique in its field. Now, again, it is my pleasure to thank Ms. Fischer from CCOG, who has organized everything, in fact, and who was decisive and instrumental in organizing this huge success that we are able to announce today with your help and with your support. Now, a very, very important point is that after having staged the seminars and organized the seminars, we will aim at a live event, hopefully after having overcome this terrible pandemic which has struck us. And we'll have this live event on November 25 and 26 in Vienna, nearby at the airport. And you are very, very invited and very warmly invited to join us. Please come and discuss with us and continue this important success that we had by having the webinars organized. Now, finally, and most importantly, but not the least, and unfortunately the last, I have to thank Xavier. Xavier has been extremely supportive in our staging this event. They were courageous enough to go with us the way with webinars at a time when webinars were not as popular as they are today, and when we launched this rather visionary idea. And Xavier is again helping us to stage the event in November. Usually I do not mention pharma companies or companies from which support us that much at length, but this was truly a major decision which we truly appreciate in times where we all were going through difficult periods. So, ladies and gentlemen, it is my pleasure to now introduce and reintroduce Professor Gerald Prager, who will take over the discussion and will take over the presentations. And I, as president of CCOG, look very much forward to meet you all in person and have a hopefully warm welcome to extend to you in November in Vienna. Thank you very much.
Thank you very much, Christoph. I have to add the fourth very important point, and this is that I want to thank CCOG for providing us, expert on pancreatic cancer, the platform for interacting, for sharing our experience, for discussing new results. And this also is beneficial for other colleagues throughout the world, as you were mentioning it. So I want to thank you, Christoph, especially for providing us this very important and highly appreciated platform. Thank you. Today, it's my big honor and pleasure to also announce two discussions of this today meeting. One is Eric von Cutsem. Eric von Cutsem, I think I don't have to introduce to you. Everybody knows him. He's a full professor, division head of the digestive oncology at the University of Leuven and University Hospital Gestersberg in Leuven, Belgium. He is, I think, an author of every or almost every paradigm-changing manuscript in the field of GI cancer. He is also one of the founder of the so-called ESMO GI meeting, which took place again this year last week. And it's a very big pleasure that we have him on board to discuss novel approaches in the treatment of pancreatic cancer. The second discussions today is Junji Furuse. He's an oncologist from Japan. He's a doctor of medicine and doctor of philosophy at the Chiba University in Japan. And he's the head division of hepatobiliary pancreatic oncology at the National Cancer Center Hospital East in Kashiwa, Japan. So first of all, I want to give you an overview, some slides as the basic for the discussion of today. And I would like now to ask for opening the slides. My today's talk is about the modern treatment approaches in metastatic pancreatic cancer and continuum of care. So these are my disclosures. So we all know that pancreatic cancer has an increasing burden. Especially in the Western world, we have seen the last decades increasing numbers and with an incredible high rate of death last year within Europe. Only within Europe, about 130,000 people dying of pancreatic cancer. Unfortunately, it's one of the diseases with increasing incidences and therefore also increasing numbers of death. And pancreatic cancer will soon become the number 2 killer of solid tumors in the Western world. And so this is really alarming. So we are facing an increased pancreatic cancer burden. And unfortunately, at the moment, we don't know how to bring these numbers down. For that, it's very important that we have some treatment approaches in hand. And we know that most of our patients, unfortunately, are either diagnosed with metastatic pancreatic cancer at the time of first diagnosis or will experience a relapse of the disease and might be then considered in a later stage of their disease as metastatic or non-curable. However, in the year 2021, we know that we have for those patients first-line treatment options, second-line treatment options, and those patients who are fit enough to see a third line, we now know what to do and what we can offer these patients in the third line as a continuation of care. We see our patients in the meantime living 12 months or longer. So there we make some step forwards in the prognosis of our patients. Although I have to mention, I will show you the slides, there is no paradigm-changing treatment as we have seen it in lung cancer or kidney cancer with the introduction of immunotherapy. So we are still waiting for these paradigm-changing treatment approaches. So how important is the progress that we have introduced novel treatment approaches? We did an analysis in our center at the Comprehensive Cancer Center in Vienna to evaluate if the introduction of novel treatment options is indeed beneficial or is it only costly. So we subgrouped patients with the first diagnosis between 2011-2013 and compared those patients with patients diagnosed between 2014 and 2017. We know that many new approaches like liposomal irinotecan or olaparib were later on introduced and might be beneficial for those patients with a later diagnosis. We looked on the overall survival as a hard endpoint, and we were interested whether those patients diagnosed later with a metastatic disease do live longer, do have a better prognosis. On the very left-hand side, you can see that those patients diagnosed between 2011 and 2014 and 2017 are living longer when compared to those diagnosed between 2011 and 13, with 12-month survival rate of almost 50% compared to 37%. But even after 24 months, 17% were still alive compared to 8% in those patients diagnosed earlier. The difference in the median overall survival was statistically significant with a hazard ratio of 0.77. We also observed that about 2/3 of our patients were fit enough to see a second-line treatment. And this was also remarkable. The improvement in the prognosis from start of second-line treatment was also statistically significant in favor of those patients diagnosed later on. So most of the benefit in the prognosis was due to introduction of novel second-line treatment options. Not that much in third line, but it was important to see that 1/3 of our patients are fit enough to see a third-line treatment option. But from this data, you might conclude that the choice of second-line treatment and the introduction of novel treatment options is crucial. So what is the treatment algorithm for metastatic pancreatic cancer? Teresa Maccarola did do this treatment algorithm slide, and she was kindly providing us the slide as a basis for discussion. So in the palliative treatment, we have two treatment options: nab-paclitaxel, gemcitabine, or FOLFIRINOX. Many centers are using modified FOLFIRINOX, which is not the same regimen as it was used in the trial from Eckert and Brodish, published in the New England Journal of Medicine. However, it is expected to have comparable efficacy with a better toxicity profile. But if you start with nab-paclitaxel gemcitabine, as shown in the IMPACT trial, you have second-line treatment options, which are also supported by prospective randomized clinical trials, like the usage of liposomal irinotecan plus 5-fluorouracil or oxaliplatin-based combination treatments. You have also certain treatment options for those who haven't been treated before with liposomal irinotecan. You might go in the third line for this option, or the other way around for platinum-based treatment. If you start with modified FOLFIRINOX, it becomes in second line a little bit more tricky because nab-paclitaxel gemcitabine has only been tested in first line, and there is only limited data whether nab-paclitaxel plus gemcitabine is also efficient in second line. However, you might go for gemcitabine-based combinations or as a monotherapy. What we also see and observe is that the choice of treatment, first-line treatment, is affecting the choice of a second-line treatment. However, the choice of first-line treatment seems not to affect the overall survival of our patients. This is an analysis from Austrian centers with more than 400 patients. It's a post-hoc analysis. But in the propensity score analysis, which you can see on the right-hand side, there was no superiority of one regimen over the other. Notably, there has never been a head-to-head comparison trial comparing nab-paclitaxel gemcitabine with FOLFIRINOX. So all the data we have in hand supporting us to choose one or the other regimen are derived from registries or propensity score analysis. So from this Austrian analysis, however, there is no favorable choice of first-line treatment. Although we know the toxicity profile is in favor of nab-paclitaxel gemcitabine. This is very much supported by meta-analysis, as it's shown here. In this analysis, it's clearly shown that there is no favor of one over the other regimen. The overall survival in this data had a hazard ratio of 0.99, which was, of course, not statistically significant. And also, if you look on the right-hand side on a Japanese analysis, we also cannot see a favorable treatment regimen compared one over the other. So from the efficacy or prognosis, the choice of first-line treatment should very much depend on an individual decision and on the toxicity profile. But it's not true that one regimen seems to be more active than the other one. So the question is then, what do we do after failure of first-line treatment? We can expect a median progression-free survival of the first-line treatment of approximately 6 months. So we have already, when we start the first-line treatment, think about what is the most appropriate second-line treatment for our patients. As you have seen the data from our center, approximately 2/3 of our patients will see a second-line treatment. So if you start in first-line with a 5-FU-based treatment, you might switch for the fit patient to a second-line gemcitabine-based treatment. The same, but the other way around, is if you start with gemcitabine-based first-line, you might go to a 5-FU-based second-line treatment, and then you have two options. Either you go for liposomal irinotecan, or you combine it with oxaliplatin. And I think we are very consistent if we recommend for those patients who are not fit enough to see a second-line treatment, a best supportive care alone strategy. So what's about the combination of 5-FU with oxaliplatin? There are some conflicting, or let's say inconsistent data. If we compare prospective treatment regimens and clinical trials, there was the CONCO-003 trial, which was a clinical phase 3 trial, where fluoropyrimidine alone was compared with oxaliplatin fluoropyrimidine combination, the so-called off regimen. The primary endpoint was met. There was a statistically significant increase in the median overall survival, but also progression-free survival. So clearly, positive trial with, let's say, a little bit more complicated treatment regimen. The other trial, however, the PANCREAS trial, was also a prospective randomized trial in the second-line setting with, let's say, quite comparable study population of patients who were all pre-treated with gemcitabine and refractory to gemcitabine. And again, control arm was infusional 5-FU leucovorin, and the experimental arm was a FOLFOX regimen. However, there was a statistically significant inferiority when it comes to median overall survival, and no benefit in terms of median progression-free survival. An Asian trial combining S1 with oxaliplatin was a clinical phase 2 trial, but also this combination did not lead to an increase in the prognosis or progression-free survival of this Asian patient population. So there is some, let's say, inconsistent data in a second-line setting of oxaliplatin fluoropyrimidine combination. Indeed, I'm very often asked, can we use irinotecan plus 5-FU, so the conventional irinotecan? There are limited data. This is a South Korean trial where you can see that the conventional irinotecan 5-FU versus a FOLFOX combination did not show any convincing PFS or overall survival data with a median overall survival of about 4 months, no responses in the patient population. Limited number of patients though. However, we have recently seen data derived from the so-called Napoli 1 trial. This was a clinical phase 3 trial, prospectively randomizing patients to liposomal irinotecan alone, 5-FU leucovorin alone, or the so-called Napoli regimen, which is a liposomal irinotecan plus 5-FU every other week. And in those arms, more than 100 patients per arm were treated with the primary endpoint over survival. Notably, this is also second-line trial design, so all patients were previously treated with a gemcitabine-based treatment. You might be aware of the outcome. This was a positive phase 3 trial. The primary endpoint was met with a median overall survival of 6.2 versus 4.2 months when compared to 5-FU leucovorin alone. Also, the progression-free survival was statistically significant in favor of the combination. The overall response rate was 17 versus 1%. We know in second line we probably not necessarily need a response. However, it demonstrates how active this chemo combination might be. We also did an analysis in our center and tried to compare patients in the second line treated all pre-treated with gemcitabine-based first line, whether oxaliplatin plus fluoropyrimidine is the same active as liposomal irinotecan plus 5-FU. And what we have learned from this post-hoc analysis was that liposomal irinotecan 5-FU seems to be more active, with all limitation of a post-hoc analysis, but the difference was statistically significant, with a median PFS of 4.4 versus 3.4 months. And notably, we did see more long-term survivors. So after 4 months, 60% of the patients treated with liposomal irinotecan 5-FU were free of progression versus 35% of the patients treated with oxaliplatin. However, the pancreatic cancer is an example of limited success rates in clinical trials. So while in the last decade we did see new treatment regimens like FOLFIRINOX, the introduction of nab-paclitaxel, and in 2015 the liposomal irinotecan, within the last years many promising trials turned out to be negative. I'll give you some example. PACPH20, for instance, the immunotherapy trials with Durvalumab, ibrutinib, nababucacin, pegylated 10, all these trials did demonstrate to be not beneficial in the treatment of pancreatic cancer, with the only exception of olaparib in the subgroup of patients with germline BRCA mutation. So why is pancreatic cancer so difficult to treat? So we have learned that almost every of our patients with pancreatic cancer, the tumor bears a RAS mutation. So this seems to be a driver, but we know RAS mutations are difficult to target. We have also learned that adjuvant treatment is indeed essential. Probably everything is shifting towards neoadjuvant treatment. And then we also have learned that there are at least 2 molecular subtypes of pancreatic cancer according to their expression profile. So we have also learned that it is not enough to just target the tumor cells, but we should rather also consider the tumor microenvironment and should interfere with the interaction of tumor cells with the stroma cells. And we also have to consider the genetic diversity of the tumors. I've summarized 4 interesting approaches. You can look this up in a recent Nature Reviews publication. They call it the prime therapy approach: pathway inhibition, DNA repair, immunotherapy, metabolism, and then they have a 5th group, the microenvironment. I will try to shortly summarize those interesting approaches. First of all, immunotherapies is an immunotherapy and potential diagnostic and also especially therapeutic approach. So we have to look on the diagnosis first, because we know immunotherapies might work in those patients, MSI high, mismatch-repair deficient. And we have seen data also considering pancreatic cancer patients with mismatch-repair deficiency having a benefit of an immunotherapy. So these small subgroup of patients seems to be the only subgroup in pancreatic cancer so far having a benefit of an immunotherapy. The FDA also approved pembrolizumab, and in the meantime also nivolumab at the first tissue and tissue site agnostic indication. This was already in 2017 because the data are very convincing that those patients with a microsatellite instability or mismatch-repair deficient tumors might have a benefit of the treatment of an immunotherapy alone. This seems to be very much convincing. If you look on the data, the response rate of pembrolizumab, the overall survival data were also convincing. The moment, for technical reason, they're not displayed here. But if you take a closer look in the comparison of the solid tumors, you can also see that pancreatic cancer is in a negative way an exception again. Although these patients all were considered as mismatch repair deficient or MSI high, you can see that immunotherapy was not the same successful as other solid tumors, with a response rate of only 18%, a median progression-free survival of 2 months, the median overall survival of 4 months. And I know this is a limited numbers of patients, but this is a rare mutation in pancreatic cancer. It seems like in this comparison to other solid tumors, immunotherapy, even in the MSI high population pancreatic cancer, is not as active as in other MSI high solid tumors. We also tried to summarize in a review what are the challenges and perspectives of immunotherapy in pancreatic cancer. And we have learned also from other clinical data that this is a very good example that immunotherapy not necessarily works in every kind of cancer. These are data of a combination of Durvalumab and Tremelimumab, so a combination of 2 checkpoint inhibitors. What you can see here and what we have learned here is that pancreatic cancer is a tumor which is absolutely non-responding towards immunotherapy. These are the data of progression-free survival and overall survival with a median PFS of 1.5 and the median overall survival of 3 months, so absolutely no activity. Also, combination of immunotherapy to chemotherapy did not show to be beneficial in pancreatic cancer. Why is that? On the one hand, we have to learn that the target seems to be different. So we know, or one hypothesis is that we have M2 macrophages in the tumor tissue microenvironment, which is immunosuppressive or considered to be immunosuppressive. We know from genetic factors that pancreatic cancer only bear few somatic mutations. There might be some physical factors of the high interstitial pressure and the dense stroma. And of course, there are immunosuppressive cytokines expressed by pancreatic cancer, among them TGF-beta, but also many others. So one idea is to convert these M2 macrophages into M1 macrophages because M2 macrophages are considered to be downregulators of immune response, and we know that M2 macrophages are accumulating around pancreatic cancer. The question is, what is the exact time point? When do we have to convert them? Is this really clinically meaningful? So a lot of more studies have to be done to understand the role of M2 macrophages in pancreatic cancer. There are some ideas how M2 macrophages might be converted, and this is at least one hypothesis how we might convert patients to be more immunoresponsive when compared to those M1 macrophage embedded tumors. Another interesting approach is a pathway inhibition. We know that there are two major signaling pathways involved in pancreatic cancer. One is the RAS-MEK-ERK pathway, the other is the TGF-beta pathway. And we have learned that almost every patient, or 9 out of 10 patients with pancreatic cancer, they have a RAS mutation in the tumor molecular characteristic. And this seems to be somehow a big driver of the tumor biology. This is shown here by the Cancer Genome Atlas Research Network. You can see it on the very top. The most common somatic mutation is a key RAS mutation, followed by p53 mutation. So one idea is, if we have this mutant RAS mutation, which is driving the tumor to abnormal growth and proliferation, that we interfere with this driver mutation. There are some interesting approaches from several companies interfering with one KRAS mutation, which is G12C. It seems to be more easy to inhibit, as the system bridge can be more easily targeted. And it seems like that this G12C mutation might be a potential target in the future. However, it's a rare subtype, and only about 1% of the pancreatic cancer patients are being the G12C KRAS mutation. Another rare subtype is the TRK fusion. In less than 1% of our patients, normally they do not have a RAS mutation. You might detect NTRK gene fusion, which leads to TRK fusion proteins. And we have now TRK protein inhibitors, and these inhibitors also seems to be active in pancreatic cancer, as in these trials, in these basket trials, pancreatic cancer patients were also considered with some good responses if you can detect TRK fusion protein and you treat those patients with one of these TRK inhibitors. Here in this slide, it's demonstrated to be targeted with larotrectinib. This is also approved in Europe. You can prescribe larotrectinib or entrectinib to patients with TRK fusion protein. Another interesting approach is, of course, the DNA repair mechanism. There is expected that you might find in almost 1 out of 5 or 4 patients that there is a DNA repair defect, and you might use this information to target this defect with an approach. The DNA repair system, most important defect is the BRCA mutation. We have seen data from BRCA1, BRCA2 mutations. However, BRCA1, BRCA2 germline mutations might be expected in about 3% of our patients. There are some data, but limited data, on other DDR mutations like PIPE2, ATM, CHEK1, and 2. But all in these subgroups, you might use this information, as there is an accumulation of genetic alteration and genomic instability, and this might enhance the therapeutic resistance. Recently, we have seen data from the so-called POLO-Trial with the limitation of BRCA germline mutations. All these patients were pre-treated with cisplatin or platinum-based, either cis or oxaliplatin-based first-line treatment. And if there was a disease control for at least 16 weeks, patients were liable to be randomized 3-2 for olaparib or placebo. You might be aware that the primary endpoint in progression-free survival was met by a statistically significant improvement of progression-free survival from the time of randomization of the patients. However, the secondary endpoint overall survival was not statistically significantly different. Another approach is the extracellular matrix, as I have mentioned before. We should try to interfere also with the extracellular matrix. There are different approaches. how to interfere with stromal signaling directly with the stroma cells, potentially with the as immune regulator, or with the extracellular matrix itself, like the hyaluronic acid. There are different very complex mechanisms where you might target also angiogenesis, where you might target also proteolytic enzymes like metalloproteinases or serine proteases. But all in all together, we have seen already first data, one derived from the MET-PDAC studies, and then there is an ongoing clinical phase 3 trial using an antibody against the connective tissue growth factor, the so-called Pamrevlumab antibody. We have learned that MET-PDAC plus nab-paclitaxel gemcitabine was a negative trial. Pamrevlumab, however, there is some hope in this new antibody targeting the connective tissue growth factors. There is a clinical phase 3 trial worldwide going on in the neoadjuvant setting for locally advanced pancreatic cancer patients who are all treated with a chemotherapy, placebo-controlled prospective randomized study plus minus Pamrevlumab. The preclinical data are very convincing, showing that this antibody might indeed lead to a better response towards the neoadjuvant treatment approach. The treatment regimen of phase 2 trial was limited numbers of patients, but had the target to have a surgical exploration and successful resection rate. This limited data did also show that there was a decrease in metabolic activity by the addition of Pamrevlumab when compared to chemotherapy alone. The clinical phase 3 trial is currently recruiting patients and has also some the endpoint of surgical exploration 4 weeks after the last dose of chemotherapy with the limitation as protocol-defined criteria for surgical exploration. And last but not least, we can interfere with the metabolism. There are clinical phase 3 trials going on, for instance, with the Vimistat, which is also active in acute myeloid leukemia, and is now currently recruiting in a phase 3 trial in pancreatic cancer together with a chemotherapy. So let me summarize. Pancreatic cancer is the third leading cause of death. Its incidence is increasing, characterized by an aggressive biology, late onset of symptoms. And it seems, or it is like that pancreatic cancer is more difficult to treat compared to other solid tumors. We know that chemotherapy has a limited activity, but by the introduction of novel treatment options, even with chemotherapy, we could improve the prognosis of our patients. We have now more and more patients with metastatic pancreatic cancer living more than 1 year. There are some interesting novel approaches which are summarized as the prime treatment approaches, and they give you a short insight on this. So I thank you very much for your attention, and I would like now to open the discussion and want again to welcome Dr. Furuse and Dr. van Cutsem. Thank you for joining us today.
Thank you very much, Florian.
Thank you. I'm very pleased to join you.
Thank you very much. So, Eric, first of all, I want to congratulate you for the big success again, this World Congress of GI Cancer. And so would you like to give us a short summary of the most interesting abstract
camera is different.
From the ESMO GI meeting when it comes to pancreatic cancer? So was there something you want to highlight here today?
Yeah, in pancreatic cancer, thank you, Gerald, for this kind words. It's also thanks to your contribution and of many others, the speakers and faculty. ESMO GI was indeed very good. We had a lot of new data. However, in pancreatic cancer, let's say there were not so many practice-changing data this year. We have seen some updates. What was new is the final analysis of the adjuvant study with gem nab-paclitaxel compared to gem in the adjuvant setting study, which failed to meet the primary endpoint for discussions that were held in the past already on regarding the endpoints in this setting. But now there was a presentation by Margaret Tempero on the final overall survival results in this study. And speaking on that, FOLFIRINOX remains the standard option for patients in the adjuvant setting. There is probably a small benefit from gem nab-paclitaxel, but it's never going to be approved in this regard because of the more important benefit of FOLFIRINOX and because of the fact that the primary endpoint of gem nab-paclitaxel was not met, and for technical reasons partly, and partly also for the fact that although there was efficacy, the efficacy seems in the adjuvant setting a bit less than what we have seen with FOLFIRINOX. So that's an important data set. That was a new data set that was presented. We didn't see any, unless I forget it right now already, forgot it, we didn't see any new, let's say, major new positive data in pancreatic cancer. There were no at ASCO, there were no at this meeting at ESMO GI. There were the data recently this year presented in the NRG fusions, which is a very rare subgroup, a multi-tumor trial with the Merus drug that showed efficacy in the setting. And for the rest, in pancreatic cancer, it was more developing the concepts in this regard to see into the discussion points that were there.
Thank you so much. May I ask, Dr. Furuse, can you tell me, here in Europe, we try to treat every patient in the adjuvant setting with FOLFIRINOX, with the modified FOLFIRINOX regimen. Is it the same in Asian countries or in Japan? Do you try to provide FOLFIRINOX, or is this not that much, let's say, accepted in Japan in the adjuvant setting for the fit patients?
Regarding adjuvant setting for pancreatic cancer, Japan is in Japan, FOLFIRINOX as the adjuvant setting is not approved for pancreatic cancer, but our phase 3 trial using S1 versus gemcitabine, very excellent OS was achieved. So we used S1 as adjuvant setting, but some patients would have a benefit of modified FOLFIRINOX as adjuvant setting. So we ask government to approve modified FOLFIRINOX for adjuvant setting right now. Okay, and concerning the EPIC data, this was the trial mentioned by Eric von Cutsem right now, which was a negative trial in the adjuvant setting. Do you use nab-paclitaxel at all in the adjuvant setting in Japan, or is it just the first line in the palliative setting? Actually, yeah, as APAC trial did not meet the primary endpoint. So in Japan, also gem nab-paclitaxel is used for first line setting for unresectable pancreatic cancer right now.
May I ask you, Eric, when you treat a patient with FOLFIRINOX in the adjuvant setting, and let's say after 5 months there is a relapse of the disease, do you consider then to reintroduce a fluoropyrimidine-based first line, or do you go then for sure for a gemcitabine-based first line treatment?
Yeah, if there is a fast relapse at the end of FOLFIRINOX or 5 months after stopping FOLFIRINOX, so within 6 months, we for sure consider that as fast. then we would go for Gemna-paclitaxel. We would not reintroduce at that moment the fluoropyrimidine-based chemotherapy in the after a relapse after an adjuvant chemotherapy, even if it would be after 12 months. If patients would have a relapse, FOLFIRINOX, and then 12 months later, I would always treat these patients with Gemna-paclitaxel if they were treated in the past with FOLFIRINOX.
May I also ask you, Eric, the checkpoint inhibitor trials were so far totally negative. Do you think it's already the end of the story, or is it just, let's say, a little bit more tricky and we need novel combinations? A question to both of you, of course. Do you see a future for checkpoint inhibitors in the treatment of pancreatic cancer? Or do you think, no, the trial data, they were totally negative, we should not waste our time, it's the wrong tumor type and we should not go there?
It's the wrong tumor type for a PD antibody or PDL antibody alone. I think, however, we should look at new types of immuno-oncology agents in combination. I don't think that there the story is over. If you would then ask me which is the next one that makes sense, that's more difficult. But let's say new concepts of immuno-oncology combinations, yes, in this situation. And also, even in this very small group of MSI-high patients, as you said, the activity of a PD antibody is lower in an MSI-high pancreatic cancer than it is in other MSI-high tumors. Even in this setting, we need to go for combinations for this small group of patients. Combining a PD antibody with with another class of agents, probably even not a CTLA-4 antibody, but probably some other new innovative immuno-oncology agents.
Exactly.
Actually, yeah, in Japan, we expect the combination with IO with radiotherapy. So we have just started phase 3 trial between S1 chemoradiation versus S1 chemoradiation combined nivolumab for locally advanced pancreatic cancer.
So this is within a trial, or this is already approved in Japan? Do you do this regularly?
Not approved. Registration trial, not industry, our investigator trial. We get nivolumab from Ono pharmaceutical company, donated.
Okay, so these are the locally advanced patients, so non-resectable, considered non-resectable. And can you tell us a little bit about this trial? What is the primary endpoint? Is it response, or is it overall survival, or what are you looking at this trial?
We include borderline resectable and unresectable locally advanced disease, and primary endpoint is OS, overall survival.
It's a very interesting approach. So,
yeah.
Do we use radiotherapy also in the adjuvant setting in Japan? So outside of clinical trials?
Not adjuvant setting. Some institutes try neoadjuvant setting chemoradiotherapy.
Eric, same question to you. Is there any role of radiotherapy in the adjuvant, let's say R1 resected, or let's say some...
No, we don't do any radiotherapy in the adjuvant setting. I don't think there are enough data in the adjuvant setting to do that. We do it occasionally, not very often in the neoadjuvant setting, but we start in borderline resectable patients as standard in our center with FOLFIRINOX. If there is a response, but if we are still in doubt that the tumor will be resectable because of encasement of the blood vessels, for instance, after 4 months of treatment, then we may go give these patients stereotactic radiotherapy in order to try to escape, in order to try to make them resectable. So that's one indication. And another indication is in the clearly completely locally advanced, completely unresectable disease, where we may give chemotherapy for a longer time. The patient was responding, didn't develop metastasis. Tumor, of course, is not resectable. But in order to maintain the response and to control the disease and to give the patient the option of a drug holiday, we may give we may do a stereotactic radiotherapy. And the third one, but that's occasionally, that's when there are major pains, when patients have retroperitoneal infiltration of the local tumor with invasion around in the retroperitoneum and causing a lot of pain that is not controllable with celiac axis block or with normal pharmacological painkillers. Then we may also do radiotherapy. So that are the three indications for us, but we never do it in the postoperative setting today.
Okay, I want now to challenge you a little bit, because you're both the highest recognized experts in the field of pancreatic cancer, and I know many centers are starting with a treatment with nab-paclitaxel, gemcitabine, and patients might develop neuropathy, hair loss, and so on. But normally it's a well tolerated drug combination. So my question to you, when you go to second line, what do you do after failure of gemcitabine nab-paclitaxel? What is your choice of treatment in second line? Do you use oxaliplatin? Do you oxaliplatin do more in the third line setting? Is irinotecan embedded in the treatment regimens in your center? Can you give us a little bit insights in the sequential treatment approaches you have in your centers, Eric?
Yeah, we start in most patients in our center. We start with gem-nab-paclitaxel, unless there was a BRCA mutation, or unless in the beginning we had the suspicion that there was a BRCA mutation because of hereditary predisposition. Then we may embark on, or unless it's a patient who wants to be treated with FOLFIRINOX. But in the majority of patients, we start with gem-nab-paclitaxel. If they are progressive at a certain moment, then usually we give in second line today 5-FU plus Nali-Ri, liposomal irinotecan, because as you mentioned, indeed the neuropathy after treatment with nab-paclitaxel is sometimes a problem. Reintroducing, giving oxaliplatin at that moment is possible in some patients. But it's for sure not possible in all patients, and I do know that the type of neuropathy is slightly different with oxaliplatin and nab-paclitaxel. But usually in many patients we give 5-FU, folinic acid plus Nali-Ri. And then if patients are fit, but that's only a minority, we may go for FOLFOX in the third line. If in the meantime there was nothing else in a protocol or there was nothing druggable, the few percent of patients with a KRAS wild type tumor that we then explore, that we can look for HER2. We have a couple of patients for BRAF, energy, some of this NTRK fusion, some of this that's of course then the algorithm is different. But the majority of patients we will treat Nali-Ri plus 5-FU in second line. Sometimes if there was no neurotoxicity and the patient was fit, occasionally we may go for oxaliplatin based in the second line, but the majority is Nali-Ri.
But Eric, oxaliplatin, you combine it like the FOLFOX regimen or like the OFF regimen?
We give the FOLFOX, the classic FOLFOX, the modified FOLFOX for 85 and 48 hours, 85 milligrams per meter square. So the classic modified FOLFOX 4.
Okay. Dr. Furuse, so can you give us a little bit insight how you treat in Japan? You start also with nab-paclitaxel, gemcitabine, or you use other regimens?
Some institute in Japan, 80% patients receive first line using gem plus nab-paclitaxel, and 15 patients receive first line treatment for FOLFIRINOX, modified FOLFIRINOX. In our institute, 40 to 50% patients receive nab-paclitaxel plus gemcitabine as first line. And second line, nab-paclitaxel followed by NAR-85 is most common right now. But in Japan, just 1 year after approval of narairinotecan. So before approval of narairinotecan, 80% patients use for S1 monotherapy, and 20% patients receive modified FOLFIRINOX as second line. But S1 in second line is not so effective. So almost patients move to NAR-ED plus 5-fluorocovalent. So in our institute, NAR-ED 5-fluorocovalent is most common used for second line treatment.
So oxaliplatin does not play any role in later lines of treatment in your center in Japan.
Sorry?
Oxaliplatin after gemcitabine nab-paclitaxel, it's not approved, it does not play a role, or do you use it sometimes?
Yes, so first line is gem-nab-paclitaxel, followed by NAR-ED5-fluorocovalent, and then FOLFOX would be indicated, but not so many patients. So it is important to check BRCA mutation, not lose the chance of usage of oxaliplatin regimen, I think.
Okay, thank you very much. We are almost at the end, but my last question to both of you is, if you could look into the future, what do you think is the most promising approach you might expect, which might lead to a paradigm change in the treatment of metastatic pancreatic cancer? Eric, you first. I think you have probably the best overview about ongoing trials, and so I'm really curious to hear your answer.
Yeah, this time it's not easy, Gerald. Very difficult question. At short term, let's say phase 3 that will read out in the near future, of which I'm hopeful and optimistic, is the one with CPI 613, the antimetabolic agent that you mentioned at the end of your talk, the Vimestat, in this setting. There, the phase 2 data looked very nice, so I hope that the phase 3, even if it confirms part of it, then it looks bright and good in this situation. But that's, of course, still a risky project. We don't know. We will know later this year somewhere. If that trial is negative, yeah, then it's not going to be easy. And then I think it's going to take some time until we can capitalize a little bit on the increasing knowledge of some of the interactions between the stroma and the tumor cell itself, looking at some of the new projects that you were mentioning in this situation. But no, let's say, there is not one project that I will say that I want to mention. This is going to be the only correct direction. So a little bit vague answer, because it's so difficult. But key is further to work on the unraveling, systematic unraveling of the molecular targets on one point, and two, there is a lot going on preclinically and now early clinical, very early clinical, in some agents, and you mentioned some of them interfering with parts in the stroma, in the matrix, and then so that this interaction maybe also with immuno-oncology agents that can influence that can play a role. But that's going to take a couple of years before we can work that out.
Okay, Juni, you want to give your let's say perspective?
Okay, so it's very difficult question, but so I think I expect more druggable mutation to detect in pancreatic cancer too. So there are very difficult situation to get enough specimen. So I expect liquid biopsy, foundation liquid or Guardant, something would more useful for pancreatic cancer patient. So parallel druggable mutation to develop a new concept molecular target agent would be expected. And another thing, so more resectable disease would be spread. So promising neoadjuvant treatment using Gemna-paclitaxel or FOLFIRINOX or chemoradiotherapy would be expected, I think. Thank you.
So thank you very much, both of you. I was really delighted to have you here today for this interesting discussion. And I want to close this Pancreas Cancer Academy today, and looking forward, hopefully, to a face-to-face meeting in November this year. This was also very interactive with your contributions. And once again, thank you so much for your attention. Thank you, the faculty, and thank you, all the discussions, for joining this meeting. Have a good day and stay
Thank you
safe.
very much.
Thank you
Bye-bye.
very much also, Gerald, for organizing this and leading it. Thank you.
Thank you.